So the provisional diagnosis is a patient, the couple, a 24-year-old female, nulligravida, and 32-year-old uninvestigated male partner with diagnosis of primary infertility with bilateral distal tubal blocks on HSG, most probably due to genital tuberculosis.
Okay. So why do you say so? Justify your diagnosis.
Yes, sir. So, since we have the HSG report, it shows bilateral distal tubal blocks. There are the differential diagnosis which comes into our mind. One is female genital tuberculosis, other is endometriosis, third is pelvic inflammatory disease. She does not have any symptoms of pelvic inflammatory disease in the form of dysmenorrhea or abnormal vaginal discharge. She does not have dyspareunia, dyschezia, or symptoms of endometriosis in the form of dysmenorrhea, dyspareunia, dyschezia, etc. So the only factor which comes into picture is genital tuberculosis because she also has a past history of pulmonary tuberculosis approximately 14 years back. So considering this and also the findings on per vaginal examination, which shows that the left fornix has a beaded adnexa, which has the adnexa are felt, beaded appearance is there, beaded feel is there in the left adnexa. All of these point towards genital tuberculosis.
And the HSG findings.
And the
Sorry,
HSG.
I just forgot her periods were they normal? Absolutely.
Yes,
Or
sir.
any? Okay.
Yes, sir. Her periods were normal. They are regular. There were no complaints, past history and present history. There were no complaints of any menorrhagia or any scanty menses or decreased menstrual flow.
Okay, so in this case, they are normal, but quite often what can happen initially for the dear students, I want to say, when the tuberculosis happens, it's usually endometrial tuberculosis. I mean, apart from fallopian tube TB is the most common, almost 195 to 100% cases, and endometrial TB is about 70% cases. So 25 to 30% are those in which endometrium is not involved. Okay, so when endometrium is involved, and it is a bilateral disease always, tubal disease. So when endometrium is involved, initially there are ulcerative lesions on the endometrium. So during that time, patient can have menorrhagia or metrorrhagia, intermenstrual bleeding or irregular bleeding. So that's why tuberculosis is an important cause of irregular bleeding, or even in 7% cases of postmenopausal bleeding, 6 to 7% in India can be because of tuberculosis. So that's why recently, in fact, I had a patient of perimenopausal bleeding, and when we did endometrial sampling for her, I was planning to, and it the normally report comes proliferated endometrium without atypia, with atypia like that. In that case, report came to be epithelioid granuloma. So I had given her ATT, and then there was no need to do hysterectomy for that patient. So we are getting patient of perimenopausal bleeding, irregular bleeding, postmenopausal bleeding also. So initially, when the ulcerative lesions are made by TB, so it causes heavy bleeding. Okay, later on, tuberculosis will eat away the endometrium. So then patient will have Sherman syndrome, okay, like adhesions and all, and patient will have oligomenorrhea, hypomenorrhea, and can sometimes have amenorrhea also. And this amenorrhea can be primary and secondary also. I have seen patients of primary amenorrhea. My wife works in a TB hospital. She's a pediatrician, pulmonary pediatric TB expert. So she studied 28 adolescent girls with pulmonary TB and extrapulmonary TB. They were unmarried girls. She's a pediatrician, not a gynae. And she found that out of 28, 24, only 3 or 4 girls were having normal periods. 24 were having either, oligomenorrhea, hypomenorrhea, and many were having amenorrhea. So now I explained to you that why heavy period happen initially. Later on, usually most patients will have oligomenorrhea or hypomenorrhea because of the eating away of the endometrium and because of Sherman syndrome. But amenorrhea can also happen. So usually there are 2 causes of amenorrhea. One more common, especially in adolescent girls, she couldn't do endometrial sampling for them, are because of the anti-gonadotrophic effect of tuberculosis. So when patient has advanced TB, pulmonary TB, miliary TB, and other severe extrapulmonary TB, so there are certain toxins secreted in the patient, and then they have anti-gonadotropic effect on hypothalamus and pituitary. So that's why patient may have amenorrhea because of that, and that is reversible. Once we treat the tuberculosis pulmonary TB, then usually periods come back because that is reversible cause. But secondary, like amenorrhea can also be because of the genital involvement, especially either ovarian involvement or endometrial involvement. So if it is because of endometrial involvement, and then endometrium it is an important cause of Esserman syndrome. Usually Esserman syndrome is the adhesions in the endometrial cavity because of past history of DNC, especially in the prepubium, like for missed abortion, etc., then patient can have Esserman syndrome. Esserman described it in those cases. He never described it in case of tuberculosis. But we have found, in fact, these are my studies only at international level, quoted in Williams Gynae also, that tuberculosis is an important cause of Esserman syndrome in India. So apart from the DNC in prepubium or after missed abortion, and that is an important cause of Esserman syndrome, mostly Esserman described in those cases only. But we have found that tuberculosis is an important cause of Esserman syndrome in India. So that is also, that will cause the then amenorrhea. And sadly, this tends to be almost irreversible. Though we can, try to do in grade 1, then there is a grading also of Esserman syndrome, grade 1, 2, 3, 4. You can check in the various classifications are there, ESG classification and all. So if grade 1, grade 2 adhesions are like, few adhesions which can easily be broken by histoscope or by the resectoscope and all. But if the adhesions are severe, then they tend to be more vascular, excessive bleeding happen, and there is no point in cutting them, because by cutting them we can, the more are formed and patient can have excessive bleeding also, and you don't gain much, like, in the form of the fertility. So that is the sad thing and all. So that's why that is how, it occurs. So now, Dr. Tejas, to confirm the diagnosis, from this you can say that it is a case of suspected genital TB. But from at moment, we cannot start anti-tuberculosis therapy or any treatment. So we need to confirm the diagnosis. What further test will you do on her to confirm genital tuberculosis or to disprove it?
Yes, sir. Sir, so the basic investigations first is a blood profile for which we have done the CBC. And apart from that, ESR will also be done, which has not been done, which will be raised in the case of active tuberculosis. And then we will have to diagnose using either AFB microscopy or culture. So for that, we will take an endometrial biopsy. Endometrial biopsy will be taken after ovulation, around 21 to 25th day of menses, and the biopsy will be sent for the following things. The first is that acid fast bacilli microscopy. The second is acid fast bacilli culture, and the third is the histopathology. So acid fast bacilli microscopy is done using three stains. The first is a ZN staining technique. The second is auramine rhodamine staining technique, and the third method is Gabbitt's cold staining technique. In either of these cases, if we find acid fast bacilli, that confirms the diagnosis of genital tuberculosis. The second is the culture mediums. So traditionally, what we use usually in the setups is a Lowenstein-Jensen medium. It's an egg-based medium. Apart from that, Middlebrook medium is used, and then there are further culture mediums which are also used. For example, Bactec 460 is used. Bactec MGIT 960 is used. Bactec 460 is not currently preferred or used widely, but Bactec 960 is used in certain setups. And recently, a US FDA approved Versa Trek method is also becoming popular. If any of these are positive, again, it confirms the diagnosis of genital tuberculosis. The third method is histopathology. In histopathology, if we find an epithelioid granuloma or any tuberculosis, the histopath picture of tuberculosis, that again confirms the diagnosis. The fourth method, of course, is CB-NAT. CB-NAT has a very high specificity of approximately 100%, but it has a low sensitivity of 30%. So if it is positive, we definitely go for anti-tubercular treatment. If it is negative, then we will have to still rule out TB through other methods. Apart from that, the other methods that we can go for diagnosis is PCR. PCR again has a very high false positive and false negative rates. So if there is clinical signs and symptoms of tuberculosis along with PCR, then that is considered to be positive for tuberculosis. Otherwise, it is negative. And lastly, last method is there are newer methods. For example, there is interferon gamma release assay, IGRA, in the form of quantiferon TB or quantiferum gold TB. These basically are done on the whole blood, and the antibodies released against Mycobacterium tuberculosis are diagnosed in these cases. And if they are turning out to be positive, then it is diagnosis of tuberculosis. So, to make the diagnosis of TB, the present approach is called a composite review system (CRS), uh, in which
Composite reference standard.
reference
Composite reference
standards,
standard. Yes.
sorry, composite reference standards, in which multiple tests, along with clinical signs and symptoms of TB, multiple tests are employed, uh, and diagnosis of TB is done. And on the basis of that, the antitubercular treatment is started.
Okay.
And
Yeah. So just I want to highlight what Tejas had beautifully said. So in all such patient, we need to do an endometrial sampling. In that cycle, the patient has to remain to abstain. So that's why we have to plan it a month in advance. That in next cycle, either you will abstain or you will use condom, because we don't want her to, she may be like we taking it in day 21 or day 22 of the cycle. So patient might have conceived also. So that's why she needs to have abstinence in that cycle. If the patient is coming to us for the first time on day 21, we can't do it on that day because she has not maintained abstinence. So that is important. And then, as Tejas has said, day 21 or day 22, we do it. At that time, the endometrium is thickened and we can easily get a good sample. And one sample, as he said, we take in saline and then we send it for 3 or 4 tests. So one is AFB microscopy. You don't have to do all the 3 staining. Any one of the 3 staining can be done, or and then culture, usually one type of culture like bacterial culture or MGIT culture is to be done depending on the lab facility available. And then in the same sample, so this sample is to be sent in saline solution, saline. Okay, and one is for gene expert or CBNet. There's the same thing, but CBNet and gene expert, the name of the same test. So WHO and the Government of India and NTP program both recommend CBNet or this thing. And as they just said, 28 to 30% sensitivity is there, but specificity is almost 100%. But if you depend, and then histopath and of course other tests like LAMP test and all, they are still experimental. So only these 3 or 4 tests we do, and only on the basis of PCR, like NTEP and WHO, they not recommend that we should start treatment only on the basis of PCR. Though CBNet or this thing is also a type of PCR, but that is a much more reliable test. So on that basis, we can start. It is taken as good as AFB microscopy or AFB culture. The problem is that if we depend only on AFB microscopy or AFB culture and then histopath epithelioid granuloma we see, or we may even see local lymphocytosis in the epithelium or granulomatous inflammation. So all those are evidences of tuberculosis, because what happens actually in endometrium is shed every month. So there is not adequate time for the epithelioid granuloma to be formed. So that's why even lymphocytosis locally in the endometrium or granulomatous inflammation of the endometrium are also signs of endometrial tuberculosis in suspected patient like this patient. So that can be done. So if any of these tests are positive, AFB microscopy is positive, AFB culture is positive, or gene expert is positive, or histopath epithelioid granuloma is positive. Any of those tests, 4 tests, if positive, that is taken as a definite TB, and we can start ATT directly without doing any further tests because they are very reliable. But if it is only PCR positive, we don't start treatment only on the basis of PCR. And then, or in some other features that Tejas has said, I mean, like, we can do Mentox test, or better version of that is IGRA test these days, this gamma release assay test and all. But again, they are not reliable just only on those basis. They are also screening tests only on those basis. We can't say patient has tuberculosis. And in India, because BCG vaccination is given to everyone, so then this is like, they may be positive otherwise also. But if it's more than 10 mm in size, the Mentox test or IGRA test, then that is can be a case of tuberculosis. But only on alone we cannot start treatment on that. But they can put the patient a screen positive, then we can do higher test on that patient. Similarly, PCR positive. So PCR positive with IGRA with some other test, then you can take it as a probable TB. Then or PCR positive with some evidence of radiological imaging, like in your case, even if PCR is positive and HSC finding, then it can be taken as a probable, not definite, but probable TB. Or, this like you have got finding, some ultrasound finding can also be there sometimes. So that can also be a sign of tuberculosis, like, so that also we can take. a case, So I mean, if there is ultrasonic evidence of tube-ovarian mass with positive PCR with infertility patient, then that can also be a case of suspected tuberculosis, and we can do further test on them. But otherwise, as Tejas said, in this case, what other test you can do? A more definitive test in your case, Tejas, apart from endometrial biopsy?
A more definitive test, apart from endometrial biopsy, sir, definitely one test which can be done is a diagnostic hysterolaparoscopy.
Because especially in your case, when there is bilateral tubal block on both sides, and you have got some TB finding, so we need to confirm on the only HSG finding cannot be taken as confirmatory, and especially even if it is like bilateral coronal block, then it can be a case of just because usually HSG may not be done under general anesthesia. Many times there we are doing it under by giving them some sedative and all under local anesthesia or this thing. So patient may have tubal spasm, bilateral
As well.
tubal spasm. So it's maybe false blockage. So usually that is more coronal blockage rather than this one. So that is also to be seen. So that's why, and quite often we find bilateral coronal block on HSG, and when we do laparoscopy under general anesthesia, tubes are nicely patent. That can also be possible, but usually the finding which you are seeing in your patient, they are more likely to be true, and we are more likely to find evidence of like tuberculosis on laparoscopy also. And whenever we are doing laparoscopy under general anesthesia, in the same clinic, we should combine hysteroscopy also for that patient. So now, can you tell us what are the laparoscopic finding and hysteroscopic finding in TB?
Yes. So the first thing is that when do we do DH, diagnostic hysterolaparoscopy? So it is a controversial topic because one thing is that surgery should not be performed in when there is active tuberculosis, but DHL definitely helps us to diagnose TB and also prognosticate the fertility factors of TB. So it will be helpful if we do a DHL. In diagnosis DHL, we have to examine the entire abdomen. So if we move from above below, the perihepatic, perisplenic film adhesions can be present. Apart from that, there is a specific sign where the gallbladder usually is hanging downwards. It's called hanging gallbladder sign. Then as we move downwards, the ascending colon might be adherent to the anterior abdominal wall, or there can be adhesions present around the ascending colon. Then if we move below, examination of the uterus, tubes and the ovary, overall peritoneum as well as the genital organs. There would be presence of tubercles. Small miliary tubercles can be present. Apart from that, the tube will show twisting, it might show kinking, it might show peritubal adhesions, peritubal fibrosis can also be seen. And on chrome perturbation test, the bilateral spillage will not be seen. On the contrary, the dye will get accumulated inside the tube, and it might be seen in the case of by laparoscopy, specific. It is called blue python sign. So that will be seen on the laparoscopy. And apart from that, if there is a oophoritis also, then the ovary would be seen accordingly. And further on hysteroscopy, in hysteroscopy, if the endometrium is involved, then in that case, the endometrium will show a pale background. Apart from that, it can be edematous, pale, and there can be uterine synechia present in the endometrium, and even caseous necrosis, caseous necrosis, cheesy necrosis can be seen in the lining of the endometrium. So these will be findings in the diagnostic hysterolaparoscopy. Yes, sir.
Absolutely, absolutely. And yeah, so Tejas has beautifully highlighted all the findings of, abdominopelvic tuberculosis. So what is important, as he said, that we should have a 360-degree view. Don't just become Kueka Mendek and look only into the pelvis. We have to look all around. And as he said, quite often, almost in 45% patients, we have found Fidge-Hugger syndrome or perihepatic adhesion in these patients, which was originally Fidge and Hug reported it and Curtis. They reported it in case of gonorrhea. Later on, it was found in mycoplasma and chlamydia, but now we mentioned it in case of tuberculosis also. And then we have to have a look on the ascending colon on the ileocecal region, because ileocecal region TB is very common, and then ascending colon TB also is common. But by the time you go to transverse colon and descending colon, the TB is not there. So that's why ascending colon and adhesion on the right side are more common. So this has a significant bearing challenging on the surgery also, because when we are trying to put the second port, by mistake, we can go through the ascending colon. We can use the ascending colon. So never put the second port on the right side. Or even if you are wanting to put the second port on the right side, put it under the direct vision. So usually it's better idea to put the second port on the left side, because usually on left side the adhesions are much less. That is a safer bet. I mean, Dr. Jan point is there, or other points are, we call them, so can be used. And then, so ascending colonic adhesion can be there. Then we can say on the peritoneum and on the omentum also, we can get omental nodule sometimes, and we can get cages nodule on the peritoneum, omentum, and all. And then peritubal adhesions are there, hydrosalpinx is there, pyosalpinx is there, tubercles on the tube, and saggy areas on the uterus are as if white carpet has been laid there. So these are the various findings, and out of these, I mean, again, the laparoscopic finding can be divided into definite finding, probable finding, possible finding, like that. Some people divide, though there is no definite proper classification of them. But there are three findings which are supposed to be definite finding, and they are: number one, beading of the tube. So, like in your case, you have got beading of the tube on HSG. So when we do laparoscopy, we can have this beading of the tube on laparoscopy also. So that is a definite sign of TB. Then we may see tubercles, I mean, on the uterus, on the fallopian tube and posterior surface of uterus and other. So they are also supposed to be definite sign of tuberculosis. And then we can have cages nodules on the omentum, on the peritoneum, in the pouch of Douglas or other areas. So cages nodules are also supposed to be definite finding of TB. So one of those signs, even one sign is good enough. Then we label the patient a definite TB. But then there are probable signs, I mean, which alone may not be sufficient. I'm trying to develop an algorithm and a scoring system actually. So till now, I haven't been successful, but hopefully in near future, we might come out with, just like we have Jones criteria. So we are trying to make, like, the point like that. But in that case, the probable finding can be hydrosalpinx, pyosalpinx. I mean, they are not definite finding, but they are quite significant finding. Then fluid, straw-colored fluid in pouch of Douglas, peritubal adhesions, then other type of adhesions. So all these can also be features of tuberculosis, in that case. And on histoscopy also, as they just said, so same finding can be on, tubercles can be there on histoscopy also, and cages nodules can be on histoscopy also. They're also definite find. And then we can have the, adhesions, Esterman syndrome grade 1, 2, 3, 4, like that. So that also, and pale cavity. Normally the cavity, endometrial cavity is pink in color, but in case of tuberculosis, because of less blood flow to the endometrium, so tubal cavity, endometrial cavity become pale in color, whitish or pale in color, and we can have adhesions of there, and sometimes periosteal adhesions are there. Sometimes a pseudo septum can also be there. It's not a true septum, but pseudo septum because of adhesion. And then, so these are, and of course tubercles, and of course cages nodules, and these adhesion. But of course, cages nodules and tubercles are specific of TB, but the adhesions can be in Esterman syndrome, which is because of post-DNC also. But if there is no history of past DNC or any such feature, then and patient has other evidence of tuberculosis, then we will presume that them because of tuberculosis. Okay, so now you did laparoscopy, suppose, or you did endometrial sampling, and any of that did show that it is a case of tuberculosis. And then, but they just also said the composite reference standard. So that is a very important thing. CRS has been used for other extrapulmonary TB. It has been used for diagnosis of typhoid and other things also, not unique to, I mean, tuberculosis, but for genital TB we have used it. So what happens, I mean, if we depend only on endometrial biopsy, AFB microscopy, AFB culture, gene expert, or histopath, we pick up only 10 to 20% cases of genital TB. We miss 80% cases. But if we depend on only PCR, then we may pick up 200% cases. So false positive, as they just have said in that case. So that's why, and if we do so, in my practical experience, only 10 to 20% cases are picked up by definite findings of endometrial biopsy or other this thing. But composite reference standard, when we combine it with laparoscopy and histoscopy, then we tend to pick up 80 to 90% cases. In fact, most of my patients of genital TB were picked up on laparoscopy, histoscopy, and in that case also we have definite finding, probable finding, like that. So that's why we can ultimately, if we make an algorithm, we can say, whenever we take up infertility patient with some oligohypomenorrhea, with some past history of TB and all that, and then we do endometrial biopsy. On endometrial biopsy, AFP microscopy, definite TB start treatment. AFP culture positive, definite TB start treatment. Histopath epithelioid granuloma or granulomatous endometrium start treatment straight away. Or a gene expert positive start treatment same way. Or only PCR positive, but with other finding, like PCR positive with the TIBO ovarian mass on ultrasound, CT, MRI, PET, any of those, then probable TB, we can start treatment. Then PCR positive, or even if PCR is not positive, but clinic, some like oligomenorrhea, hypomenorrhea, or suspected patient, or infertility patient, or some HSC finding, then also we can say probable TB, and we can start treatment. Then on laparoscopic evidence of definite TB start treatment, like cages, nodule, tubercles, bleeding of the tube. Then probable findings of laparoscopy TB, or probable, similarly, definite finding of TB on histoscopy also can be taken at definite TB and start treatment. But probable finding on laparoscopy, probable finding on histoscopy, like that, then we take patient. We can say laparoscopy TB, so we are allowed to start treatment, and TB allow the treatment to be given to the patient. But only PCR positive, rest everything is negative, laparoscopy, histoscopy are normal, then it is not a TB, then we don't start the treatment to the patient. Okay, so now the TB has been diagnosed. Actually, I have to join some other class at 8 o'clock. Some our meeting is there with the AIMS people. So the Dr. Tejas, quickly tell us the treatment now. It is a drug sensitive TB, suppose.
Yes, sir. If it's a drug sensitive TB, then in that case we have the antitubercular treatment according to NTEP. It has two phases. One is intensive phase and second is continuation phase. We use fixed drug approach, a fixed drug combination, which contains in the intensive phase there is HRZE, that is isoniazid, rifampicin, pyrazinamide, and ethambutol. ISO one tablet will contain 75 milligram isoniazid, 150 milligram rifampicin, then 400 milligram of pyrazinamide, and 275 milligram of ethambutol. And in the continuation phase, we only have three drugs, H, R, and E. We do not have Z in the continuation phase. So depending upon, then there are weight bands. Depending upon the weight, the fixed drug combination is given. So if the weight is 25 to 39 kg, then two tablets are given. If it is 40 to 54 kg, then three tablets are given. 55 to 69, then four tablets are given, and more than 75 tablets. So her weight is 40 kg, so we will give her only three tablets. Three tablets in the intensive phase, three tablets in the continuation phase. And then we will do at the end of this entire treatment, we will do an endometrial biopsy to rule out any positive acid fast bacilli in the endometrium. And there is a role of streptomycin. Earlier, streptomycin was a part of tuberculosis elimination program, but now it is said that it is only used if there is any adverse drug reaction towards H, R, Z, or E. For example, if there is a hepatitis which is drug induced, in which case we use a levofloxacin, ethambutol, streptomycin regimen, LES regimen is used instead of HRZD. And if after doing, if the patient is progressing on these drugs, or the genital TB is not getting resolved, in such cases, we'll have to do a sensitivity test for drug resistance. And depending upon that, we'll have to start, according to the National Tuberculosis Program, a drug resistant or a MDR TB or a drug resistant TB treatment.
Yeah, probably we don't have to discuss MDR TB. In case of MDR TB, then the patient should be referred to the expert specialist, and then they are given drugs for maybe 12 months or 16 months, category 4 drugs, and which is beyond the scope of today's lecture. Such patients we should not treat. Even I don't treat them. We refer them to the experts after diagnosing them. So for our postgraduates, usually we are asked about the drug sensitive TB. So as Tejas rightly said, we can refer the patient to DOT center. They are given drug free of cost by the DOT center. So we write by laparoscopic evidence of the genital TB. I make this thing and I write it, and ATT and category 1 under DOTs, refer the patient to DOTs. So there they will, because these patients have to be notified to the government also. So the DOTs people will notify for us. Patient will be given RHZD daily for 2 months and RHE daily for next 4 months. As Tejas already said, dosage also he has said the dosage regime, and so it should be given from the government center free of cost. And plus patient get now it used to be 500, now 1,000 rupees per month for portion also free of cost. So that is the beauty of it. Plus patient will be notified to the government also. So that has to be given, and then rarely if the patient unable to tolerate, then as he said, levofloxacin and streptomycin can also be given. And of course for MDR drugs are to be given. For that I'll refer the patient to the expert pulmonary TB expert, the MDR TB expert patients, and there also the DOTS plus center can give them drugs accordingly. And usually we can do LFT test on them, and we can advise them pyridoxine also for the side effects. And but mild increase in LFT is common. We don't have to stop treatment on that basis. But if the patient is anorexic and severe reaction, then as he said, we may change the drugs. And usually many patients start to tolerate the drug gradually. So we may be able to give them our own regimen also to them. And just to complete the list, so at the end of the therapy, like 6 months and all, so we can actually repeat the test. Like we can even do lepro, histro plus endometrial biopsy on these patients. And the role of laparoscopy, histoscopy, though it's not mandatory to do, but is it that will help us in prognostication of the disease. Like suppose after giving ATT for 6 months, I'm doing lepro, histo on the patient and biopsy. PCR may remain positive for life sometimes, so we don't only depend on that. But only thing, my culture or this have to be negative, which usually become negative. So after end of 6 months, so there can be four scenarios. Scenario one is tubes are patent, endometrium is fine, or grade 1 to 2 adenine, which can easily be cut. In that case, we can give ovulation induction drugs to the patient. Patient can try it spontaneously. Second scenario, almost 30% patient belong to this category. Tubes are still blocked. In spite of ATT, tube will remain blocked because it's a tubal disease. But the endometrium is either fine or grade 1 to 2 adhesion, which can easily be cut by hysteroscopy. So these patients will be suitable for IVF-ET. So IVF-ET has a great scope. Almost 30 to 35%, 40% patients become suitable for IVF-ET after giving ATT. Now, this is the scenario number 2, common scenario. Scenario 3, both tubes are blocked and endometrium shows grade 3 to 4 adhesions, which cannot easily be cut by the hysteroscope. And there is no point in cutting them forcefully because this endometrium is not going to be receptive. So this patient, but her ovaries are fine. Then this patient can go for surrogacy. Her egg is taken, her husband's sperm is taken, and then we can use a surrogate for this. Scenario 4, I have seen of less than 5% cases. Ovaries are also eaten or ovaries become totally dysfunctional because of tuberculosis. In that case, patient goes for, because eggs are also not there, so then patient goes for adoption. So is that clear? Scenario 1, tubes are open, endometrium fine, normal ovulation induction drugs can begin, patient can try spontaneously, 10 to 20% cases only. 30% patient belong to category 2, that means tubes are blocked, endometrium is fine or grade 1 to 2 adhesion which can be cut. In this case, we do cut those adhesions and we go for IVF-ET. Scenario 3, tubes are blocked, endometrium is also gone. In that case, patient, but ovaries are okay, patient can go for surrogacy, 20-30% patient. 4 to 5% patient belong to category 4, where the ovaries are also gone. I recently got a letter from Rachel Watson from Washington, D.C., and she got a case of this. And she asked me that, is it possible that I can't see one ovary disappeared after TB? I said, yes, I have not published it, but it is possible. So ovaries, 5% patient, ovaries either disappear altogether or they don't have any eggs left. So then this patient has to go for adoption. So that is the importance of repeat lepro histo on these patients, because we can prognosticate and we can plan further treatment for this patient. So like that is how we do. So tuberculosis is an important cause of infertility, and we have to treat it medically. So that's why early the diagnosis, early the treatment, then before irreversible changes occur in the tubes and endometrium, then we can get better results. But many patients, almost 30 to 40% patients become suitable for IVF-ET. And so we should do that, and results are good. But that also should be done only after giving full ATT. If you do IVF-ET, many times you get patient of 35-year-old and all, they want to do IVF-ET, so it will be implantation failure because endometrium is too thinned out and then blood flow is less. By giving ATT, blood flow increases, endometrium becomes slightly better and the implantation rate increases. And I've seen increased risk of miscarriage also in these patients. So they have implantation failure, they have early trimester miscarriage, second trimester miscarriage, preterm delivery, IUD, IUGR, everything is possible in them. So that's why if you are starting ATT to the patient, we have to give ATT. And some of my patients have conceived on ATT. Like, while they were on ATT, they conceived. So even then we have to give ATT to the patient, otherwise they can have miscarriage and all. So this is how we treat these patients. Dr. Raina, you want to say anything final, because I have to join another
Yes,
meeting actually.
sure. So just to add to this, a lot of times we get when we are dealing with a tubo-ovarian mass or a suspected ovarian tumor, then many times you treat the patient on the lines of ovarian malignancy, but it turns out to be tubercular. So it should always be in our mind whenever we're dealing with tubal or even ovarian pathology, tuberculosis has to be in the back of our mind, especially in our country. Many times this has happened that it turns out to be tubercular.
Yeah, thank you, Dr. Raina, for that. We have, in fact, presented data on 26%. We
Yes.
collected data from AIM, MAMC, Lady Harding, GTB, 28 cases. We published
Okay.
in archives in Gynecology in public domain. You can download the article.
Yes,
So
yes.
where we opened the patient for ovarian cancer, it turned out to be abdominopelvic TB. So it can masquerade like that. In that case,
Yes.
just, take the biopsy, come out. Don't try to do any surgery. Give ATT to the patients. Okay, and because by doing surgery, we may injure the bowel and you do not gain anything, we still have to give them ATT. The only surgery advisable in these patients are drainage of the abscess or laparoscopy, histoscopy for prognosis of the disease. Otherwise, avoid surgery in these patients.
Yes.
Surgery is very difficult, more complicated, causes a lot of complications. And even laparohisto can cause more complications, so should be done by more experienced person, preferably consultants, and because the chances of complication are high.
Obvious. An entry point in laparoscopy, especially when you're suspecting tubercular abdomen, always be very careful with the entry. As you mentioned, Jan's point or Palmer's point should be used.
Absolutely, Palmer point was that.
So
Thank
you
you very
so
much. I
much.
think any question then Dr. Anna can
Yes.
answer.
Yes,
I have to
thank you.
join a meeting with the AIMS people.
Sure, sir. Thank you so
Thank you,
much.
sir.
Thank you, sir.
Thank you. But this is important
Thank
topic.
you.
Please, all of you read the
Yes,
topic
very
well.
important.
And any question we
Yes.
can discuss the next time. Thank you.
Thank you, sir.
Thank you.
So this was a very important topic, as sir mentioned, and the best place to read this topic for those who are listening is from sir's book itself. This is where I always read this topic from, and the recent most edition of sir's book, where he gives this topic very in detail. A lot of signs have been named after sir. So he's done a lot of good work in this. Some questions, Sheikh is asking, after ATT, how many days you can plan for pregnancy? As mentioned, ideally you should do a hysterolaparoscopy, see the condition of the tubes and the endometrium, and then plan. But once ATT is done, she can start planning for pregnancy immediately after. Pratnesh is asking, microbiological diagnosis always required to start ATT or clinical suspicion plus ultrasound markers works? So as per the algorithm, you can have either microbiological diagnosis along with clinical suspicion or imaging suggestive, or hysterolaparoscopy along with clinical suspicion. But sometimes if very suggestive, if highly suggestive findings are there, a very significant history is there, then also maybe on imaging you can start. But usually we look for a microbiological diagnosis in some form or a hysterolaparoscopy finding. That would be ideal to start the patient in on ATT.